That sounds crazy, right?
Yeah.
Because
that's like
yeah.
the indication that the patient needs to
The guy's hypoxic, we got to intubate him.
Yeah. Welcome to Stablish, where EMS lives somewhere between stable and ish. I'm Josh Kingston, paramedic, educator, and your host. This podcast is for crews who work the chaos, manage the maybes, and make the call when protocol meets real life. The name Stablish comes from a familiar EMS dilemma: the patient who isn't crashing, but isn't stable either. They're not critical enough to demand aggressive intervention, but they're not the kind that you just walk away from. They're Stablish, this gray zone where decisions get nuanced, teamwork matters, and judgment meets protocol. This series will roll out with our quarterly competencies, replacing some of our traditional recorded lectures. Instead of slide-heavy voiceovers, you'll get real conversations with experts. We'll break down cases, dive into clinical topics, cover system updates, and bring in guests, always rooted in practical, research-based EMS. So I'm here today with Eric Howard. He is, in my opinion, the guru of airway, RSI, everything that you would ever need to know about intubating a patient. He is going to talk to us today about RSI, and we're just going to get right into it with a question. So first off, do you remember your first tube, and what maybe, or more so, what was the most memorable tube you had?
Actually, thank you also, by the way, for doing this. This is a good idea. I have to think about that for a little bit because it's been literally 40 years ago. I do remember my first tube because I was a paramedic student, and I was in the OR doing clinical time, and it had intubated all the mannequins, the hairy heads, and all that back then. So you know how intimidating it can be being up in the operating room with anesthesia looking over your shoulder and asking you what you see and telling you to get off the teeth. And I do remember that experience because I was terrified. I was shaking like a leaf. But that was probably the best experience at intubation because I was under a tremendous amount of stress and was able to kind of work on my technique with their assistants kind of while they were teaching. And they were giving a lot of pointers that, my paramedic instructor really never taught because they do it all day, every day. But other than that, I've had probably numerous memorable intubations. I remember one was before we started doing rapid sequence intubation. And I was actually on a flight. And I still remember the nurse that I was with, and I remember the set of circumstances. It was about a 20-year-old female overdose, and she was completely unresponsive. And back then, all we used was Valium. And so some of you old-timers may remember the Valium days of intubation. And so we give this lady 5 milligrams of Valium, and just wasn't enough. And ended up being the biggest problem was she had a tongue stud. So she had a pierced tongue.
Nice. And
every time we'd stick the laryngoscope in her mouth, it was just long enough. Obviously, top and the bottom went through the entire tongue. It was just a hindrance enough that we couldn't keep the tongue out of the way. And we tried, and this was before the days that we really taught no more than 3 attempts at intubation, right? So we're really pretty strict about that now. And we didn't have that education and information back then. We didn't know anything about functional residual capacity. All the studies out that showed that any more than 3 attempts, you're probably not going to get it. And so we just kept trying to intubate. And we were probably on scene, I'm going to guess, 30 to 40 minutes just trying to intubate this lady. Wow. And we finally got it, but it was one of those pretty tense moments where, back then you didn't even look at pulse ox. We didn't have capnography.
Was she super hypoxic?
Yeah, I'm sure she was. She did live, so we didn't kill her. But that was another one that was pretty memorable that I've actually never forgotten.
Awesome. How do you feel about RSI? Like, what do you think it's a helpful thing that we have, that we do it well, that, all of those things? Like, how do you feel about RSI in general?
Yeah, well, interesting question, because we haven't been doing RSI all that long on ground EMS. I'm going to guess 15 years. We've done it a little bit longer on Lifeline, about 18 years. Our ER has been doing it for close to 20. And so when paralytics first started being used in the emergency department, by then we had went from Valium to Versed. Etomidate still wasn't really out on the market yet. And so Versed was a little bit quicker acting drug. You could give a lot more of it without complications like Valium can do. So it was a really cool thing watching the ER docs do that, because it took a while for anesthesia to let go of paralytics in the emergency department, because that was their thing. And then Dr. Shepard was Lifeline's medical director at the time, and he decided he wanted us to do it on the helicopter. And believe it or not, as staunch of an advocate as I am of rapid sequence intubation now, at first I was very much against it, and so was the majority of the flight crew. And we were like, we have no business pushing paralytics in the field. What if we can't get them intubated? We're going to kill them and all that stuff. And then, but we went through the training, and my very first rapid sequence intubation in the field, I actually became to understand pretty quickly that, this isn't that bad of a thing. We took a person and all the history of us intubating with Versed and Valium and all the difficulties that we had, and the multiple attempts, because it didn't take away all that extraneous stuff the patient did that made them difficult to intubate. Pushing a paralytic made everything nice and calm and took all that stuff away, and I realized that this actually is making intubations easier, and the fact that we're getting them intubated quicker is actually safer than what we were doing just because of that paralytic. So from that time on, I kind of embraced rapid sequence intubation, started educating myself as much as I could about it, and just tried to take the lead on being instrumental in teaching that throughout the entire region.
Awesome.
Not only to EMS, but to hospitals as well.
So how has it changed from when it first started to now?
It has changed a lot, mainly because of the research and the education that has went into it. So, for instance, I know I've already mentioned this before, but we now know that there's research out there that shows that you must limit your attempts at intubation. We know that we must limit the time that we're in the mouth. We have pulse oximetry now. Capnography doesn't help very much when they're paralyzed, but pulse oximetry, again, is really important, and we know that we can't allow them to desaturate below 90, which below 90 is cellular hypoxia. We know that our techniques have improved. We have VL, we have DL, we have supraglottic airways now that we didn't used to have back in the day. And so I think the education of it and the research of it is really what's done better. Obviously, our technique of intubation hasn't really changed all that much, even though we put out a little video a month or two ago about how to improve your technique and make sure your maybe first pass success rate is a little bit higher. Yeah. And the other thing is, when I first started teaching RSI for Mercy and going out on the road doing outreach education for EMS agencies, for ERs that hadn't started doing that yet, my RSI presentation was 60 slides. And it has evolved into now almost 300, which those of you who have sat through it know that it can be quite painful. But there's just a lot of information that we didn't present back in the 80s and 90s that we present now to actually make us more educated and better at what we do.
Yeah, like checklists and apneic oxygenation and nitrogen washout.
Yeah, all that stuff.
All of that stuff. So all of that goes into it. So speaking of checklists, so one of the things that we really kind of harp on is making sure that we are ready before we ever go into that tube,
right?
And go into the mouth. So, what kind of things have you learned over your career that, like those checklists,
right?
What have you learned that has kind of helped you and do?
I think I think a mindset of people hear the term rapid sequence, and when they hear that rapid sequence, they feel like they have to do everything fast, right? And there's no time for checklist, and I got to move. And when we do that, we make mistakes and we omit really important things. And so, even airline pilots go through checklists in an emergency. Sully Sullinger, when he crashed his plane in the Potomac, he had not the Potomac, the Hudson. I've got a different plane crash in my. Even when he lost both engines, him and his co-pilot had the time with 180 people on board to go through a checklist of what they should do. And people think that, this is something rapidly that I have to do. I don't have time for a checklist. But unless it's truly a crash intubation and your patient is actually coding right now, most of the patients that we rapid sequence intubate, we have minutes to prepare for that. And when we prepare and when we have a checklist, like the one you guys have probably seen, and Josh will probably put that up here in just a little bit, this is just a checklist that, your EMT partner can go over this with you, and they can actually recite it out to you. Hey, have you done this? Have you done this? We actually have a checklist in Hands Heavy that you can actually mark, and you can check off what you've done, unlike you can't do with this checklist, particularly here, but you can go down the checklist. But the one in Hands Heavy, you can check off what you've done. And when you go through a checklist and you kind of make sure that you've done the important things first, which preparation is the most important thing that we do.
Right.
And so you can prevent harm, and you can prevent second attempts, third attempts, all kinds of bad things you can prevent just by going through a checklist. And we really heavily encourage it. Lifeline's been doing checklists for quite some time. Almost all air medical programs do checklists. ERs are doing checklists now, so it's really something we need to embrace to make sure we're doing this in a professional manner. And really, when you think about it, those of you guys who've done, rapid sequence, know that the only fast thing about rapid sequence is once the drugs are drawn up, you push them fast and you get ready to intubate. Preparation is nice, slow, controlled. Take your time. Make sure you have everything ready. Make sure your EMT partners are ready, your firefighters are ready. And so, yeah.
So what else goes into that preparation? What else should we be worried about? Pre-oxygenation, nitrogen washout. Should we be doing all that?
Yeah. So one of the most important thing on the checklist is obviously nitrogen washout is the most important thing that we can do. There's several ways we can do that. The biggest one is a non-rebreather mask for 3 to 5 minutes. That's the quickest, because a lot of times our hospitals, our first responders, our firefighters have already started that process for us. We want to make sure that their pulse ox is high as we can get it before we intubate. This is my opinion, but there's studies out there that actually show that apneic oxygenation, high flow nasal cannula should really be done on everybody that we intubate, whether it's rapid sequence intubation or not. And especially, it's crucial that all head injuries get apneic oxygenation, so they continue to oxygenate while we intubate them, to make sure that their SATs never drop below 90. And it just gives us minutes more of what we call safe apnea, where they don't drop below 90, and can actually give us minutes to get somebody intubated before they actually drop their SATs. So the pre-oxygenation is, pre-oxygenation preparation, those both go hand in hand, they're both most important.
We've all had those difficult airways, those difficult intubations. Talk to me about how we can prepare for those in that preparation stage.
Right.
Before we ever get to that, so we can avoid that difficult intubation.
Yeah, sure. So every medic, every ER doc, every anesthesia person on this planet is going to have a difficult intubation, even a failed intubation. If you're educated in your mind who is going to be a difficult intubation before you ever get into that situation, who will be difficult to bag if you can't get them intubated, just little things like we teach in the academy, beards, obesity, micronathia, just doing that Lemon's Law, looking at your patient, identifying problems. You can look at every patient before you intubate them. Takes a 1 second size up and identify, not only is this guy going to be hard to intubate, I believe he's going to be hard to bag valve mask if I fail on my first attempt and they start to desaturate. And so obviously we don't want to bag them until they desaturate, even if we're on our third attempt at intubation. Yeah. If their sats are still, 94, 95, mainly because of apneic oxygenation, then again, no reason to rush. So.
Awesome. I know I've had a couple difficult intubations where I wasn't prepared. I just trying to get in there and get it done, and it's been probably more so difficult because I didn't prepare correctly before I had to intubate. So I know preparation is the key thing. Let's go back to that nitrogen washout. Why is that so important for RSI?
Right, good question. So nitrogen washout, what it does is, obviously you guys all know this, you've been to EMT school, and we know that the air that we breathe is 79% nitrogen. So 21% oxygen, some little inert, gases in there. So when we go to intubate our patients, when we go to paralyze our patients and they become apneic, they're only living on that high percentage of nitrogen that's in their lungs, and that doesn't keep them alive very long, and that causes your pulse ox to plummet very quickly. When we do apneic oxygenation and hyperoxygenation, not hyperventilation, that term is pretty much gone. In the nitrogen washout, deliberately we are making a conscious effort to get rid of that nitrogen that's within our lungs, and we're replacing it with a high percentage of oxygen. Then we do become apneic. We're actually, even though we're not breathing in and out, we are living off of that high reserve. For most adults, it's a 2-liter reserve. It's 20 to 30 cc's per kilogram of unused gas in our alveoli. So for me, that's about 2 liters. If you can imagine a 2-liter bottle full of high percentage oxygen, yeah. My body's actually utilizing that to keep my pulse oximetry high, to keep my FiO2 high. So I'm less likely to desaturate and become unstable and all that other bad stuff that can happen to hypoxic people when we intubate them or even after we intubate them.
Wow. I did not realize it was that much that we could replace and get in there.
It is. And when we talk about functional residual capacity, if anybody wants to, if you're bored enough, Google it. Just Google functional residual capacity and you'll get over 500,000 hits. That is how extensively it's been covered in the last probably 15 years. Even after we started doing RSI, they were doing more studies about FRC and the importance of that. And then just like 5 or 6 years ago, then came the studies on apneic oxygenation and how important that was. And so if you do proper FRC, nitrogen washout, and you do apneic oxygenation, it actually gives you 2 to 3 minutes above what your nitrogen washout would give you to not have to rush during your intubation attempts, because you should have a pulse ox coach telling you what your pulse ox is. And if your EMT or your other paramedic is constantly telling you you're at 95, you're at 95, you're at 95, then we don't have to rush. We know that we're good.
So how much time do I get then? Like from the time that I start my attempt to when I realistically should pull out? How much time do I actually get?
What I always teach is you have minutes. There's a realistic phase and an unrealistic phase, and some people will say that if I'm in there for 3 or 4 minutes trying to get somebody intubated, that that's a little bit unrealistic. But in actuality, if your pulse ox is still okay, then you are still okay because you're not hypoxic. You could also argue that most paramedics or most ER docs would have already exhausted their first attempt. What did I do wrong? How can I correct my second attempt? Go in with your second attempt. Maybe you're changing blades, going from a Mac to a Miller to a Mac, a 2 to a 3. And you should have exhausted your 3 attempts within, 3 to 4 minutes. You don't want to just hang out in there, because if you're in there for 2 minutes, you're not really figuring out what you're doing wrong and how you can correct it. And so people also, they'll use the kind of the complaint of, well, their CO2 is going out the roof. You know, their capnography is going to be 150 by the time we get them intubated if I'm in there for 4 minutes and they're not breathing. And that's not really valid either, because within 7, 8, 9 breaths, you've blown that CO2 off, and they should be back to normal capnic or where they were before you intubated them.
Awesome. More time is great. All right. So moving on, let's move into our induction meds and paralytics.
Yep.
So we currently have Etomidate as an induction and ketamine.
Right.
So what makes the difference between the two? Like, when do I use Etomidate? When do I use ketamine? What? Why should I use one over the other?
Right, yeah. Another good question. So when you look at our RSI protocol, and, you know, we haven't always carried ketamine. So when we switched from Versed as an induction, which was one of the best things we've ever done, because Versed is not a good induction drug. It takes too long. The onset is 3 to 4 minutes. Your Succinylcholine or your rock has already paralyzed you, and you're not really even sedated yet. So Versed is that good post-intubation tube management of titrating and keeping them kind of sedated. So anyway, we'd always just had Etomidate, and there are lots and lots of studies on Etomidate. Etomidate is one-arm brain sedation, works almost within seconds. It's cerebroprotective. It's very cerebroprotective, and it does it by that CMRO2, which is cerebral metabolic rate of oxygen.
So it's good for head injuries,
Yes,
right?
yes, it is the best for head injuries. And basically what it does is it basically shuts your brain down and says, you know what, I really don't need oxygenation or perfusion right now because I'm stoned. And the Etomidate does that. Ketamine doesn't offer that protection. Even though ketamine doesn't cause ICP issues like everybody thought it used to, any ICP issues that you would get from ketamine are not really relevant and not really clinically significant. But, and again, I know my opinion, and I think this is shared because of the literature and a lot of the research that I've read, and if you guys ever can get on airwayworld.com, they do tons and tons of airway research. They have several authors that concluded that Etomidate is probably the best rapid sequence profile of any drug that's out there, with the exception of propofol, which we're not going to ever have.
Right.
And so Etomidate is quick, it's cerebroprotective. Ketamine is great to use in the place of Etomidate when it's indicated. And if you look on our protocols, Etomidate is always listed first. It is the drug that Dr. Lewis would prefer that we used first in a vast majority of our rapid sequence. Just because of its safety profile, you can give it to hypotensive patients, you can give it to hypoxic patients, and it's still a safe drug. And again, just like I said, a really quick onset. The only disadvantages of it, it's short acting. So you got about 8 minutes. But again, I think in that CMRO2 only lasts for about the half-life of Etomidate, which is probably 4 minutes. And so, but I would think that most paramedics would have done their first attempt, second attempt, third attempt.
Right. So we really just want that cerebral protectiveness for
Yes.
the intubation itself.
Yes.
We're not worried about, I mean, we are worried about long-term ICP
Right,
and
short
various
term.
things. But
Right.
in the short term, because we are, when we intubate, we're causing lots of pressures to go up everywhere in the body.
Yeah, so
we've got to have that.
Yeah, one of the bad things about intubation is, and it's more people are, some people are more susceptible than others, is that depression of the laryngeal nerve when we get in there with our laryngoscope blade. It can cause hypertension, hypotension, tachycardia, bradycardia, increased intracranial pressure. And so we're just trying to prevent that ICP from going out the roof during the intubation attempt. So that's why it doesn't do any good to give Etomidate after they're intubated.
Right.
Number one, it's too short. Number two, it doesn't do anything for their ICP. And so, but when I would choose to use ketamine is, and this is a little bit controversial too, is people who are septic. So etomidate has been shown, they know it does cause adrenal cortical suppression. So basically almost like an Addisonian crisis, but in healthy people, we rebound very quickly and it is no sequelae. On ketamine, doesn't do that. And so people who are septic, ketamine is probably the better option. People who have asthma and respiratory issues, ketamine is a bronchodilator. So it's probably more advantageous to go with ketamine on respiratory, specifically asthma and COPD. CHF isn't really beneficial to use ketamine over etomidate. But like the last study that I actually listened to a podcast on airwayworld.com, one of their main airway educators or one of the main airway researchers said it's basically hard to beat the profile of etomidate for any rapid sequence that you do. And then the other thing that we used to teach that I've kind of had to change that as well, multiple studies out there show now that we thought that ketamine would increase blood pressure, and we know it increases heart rate too, but we thought it would be better to do ketamine for maybe trauma patients or people who are hypotensive because it does increase cardiac output. They also found a really, really high correlation in post-intubation hypotension and bradycardia in the critically ill patients who actually get ketamine, which really went against everything that we had ever taught. And all these studies, I mean, you can Google any of this information and get the same information that I'm kind of spouting out too. But, you know, there's so many studies out there that show that etomidate should never be given to septic patients. And there's that other subset of studies that say it really doesn't matter. So it kind of, what study do you believe?
Right.
And so it kind of swings both ways.
Yeah. Let's move on to the tube itself. Okay, so the ET tube. You know, we've got all these options now. We've got the McGrath. We've got direct laryngoscope. We've got you know, even our backups like the eye gel and criking a patient and all that stuff. As far as like your preference, video laryngoscope or direct laryngoscope?
Another good question. So you ask the old school medics and they'll say, oh, you know, screw that video laryngoscope. So we have VL, video laryngoscope, DL, direct laryngoscopy. There are studies that actually cite that your intubation success rate first pass go up with video.
Yeah.
Laryngoscopy, which was my big push to get these on the truck, on every truck, not just supervised vehicle. And it's going to happen. It's just a matter of time and money. You know, they're expensive. And that's the big thing between them is video laryngoscopy is expensive and direct laryngoscopy is cheap. Everybody's got a laryngoscope on there. The downfall of video laryngoscopy is trauma, bloody airways, vomit, a lot of secretions. You're just as good probably go with direct laryngoscopy unless you're really good at the salad procedure.
I was going to say, we've got the salad, we've got those Ducanto.
Yeah, the Ducantos, and you know, if you can do it correctly and you can do continuous suction while that video laryngoscopy is ongoing, then maybe you can see just as good. The old fogging issues are gone. That's not really an issue anymore. They've corrected that with heated tips on the lights. But you know, the downfall that I see, and it depends on where you go to school, who taught you how to intubate, what your technique is like. There's really no prying, and there's really no heavy lifting with the airway when you're using video laryngoscopy like it is with direct, because you're displacing tissue to try to see direct laryngoscopy. You don't really have to do that with video laryngoscopy because it's taken all that away. And now you're just doing hand-eye coordination, trying to get that tube to go where you want it to go to what you're seeing in the screen. So there's some pretty good evidence that a VL is safer and increases first pass success rate and causes less trauma.
But we also don't want you to get rid of that direct laryngeal.
Right. It's always a skill you should fall back on.
Right, yeah.
Yeah.
So-
So it's like if we IO'd everybody, we'd lose our IV skills if we so that's something that you don't want to lose. But and I think if you clinically choose which patient you should do one or the other on, and those patients are going to be few and far between. But from my experience with video laryngoscopy, I would probably pick it every time.
Keep kind of going in that line with the tube. So my preference, and I know this is not yours, because we've had this conversation before about the Kiwi method and using the bougie as a stylet. And me personally, I've done it a couple times on a patient, and it's worked out tremendously well. And that's just me. I mean, that's how I prefer. When I first learned, that wasn't even like a thought.
Right.
It was, put the stylet in there. You only use the stylet. I didn't even know what a bougie was until I came to Mercy, really.
Right.
Because we just never learned with a bougie.
Right.
It was always on a mannequin with a stylet. And even when I went and did surgery rotations, it was, stylet, that type of thing.
Right.
Never had to use a bougie. And then we got here, and in the past probably 2 or 3 years, that Kiwi method has come out, and I kind of latched onto it. I like it as far as like intubating, because I've got that little bit of leeway with that bougie, that bougie coming out of the end of the tube, and I can thread that in through a little bit easier than I can the tube itself.
Right.
So I mean, is that something? What's your preference on that stylet or bougie?
So I think the bougie is fine to use with the Kiwi method, and if you guys aren't familiar with what the Kiwi method is,
I'll put a picture up.
Okay, put a picture up on there, and it's basically a non-traditional use of the bougie for what the bougie was intended. Not to say the Kiwi method is bad, but if you have a grade 1 or 2 view, I think the Kiwi method is perfect because it acts as your bougie and your. But if you have a grade 3 view and all you see is epiglottis only, since you have a second layer of plastic over that first layer of plastic, and the whole benefit of the bougie is to know if you're in the trachea or the esophagus because of tracheal clicking or the tracheal rings, then you're not going to feel that with a grade 3 view, and you'll still be blindly stabbing. And again, that's, if you're going to use the Kiwi method, if you're going to use a bougie, I like guys to use a bougie just to get used to the use of a bougie. So when they have a difficult airway, they're pretty practiced up with a bougie. So you don't need a bougie with a grade 1 or a grade 2. Bougies come in, and even a grade 4, because you're blindly sticking a bougie and have no clue where it's going. We were all trained to use a stylet. Anesthesia really doesn't even use stylets because of their environment, and they're so good at what they do. We started really embracing stylets because of our environment, and our ambulances set out in the hot, and those ET tubes become very pliable, and you get a tube stuck on a dry cheek and it just wants to bend on you, so we know that we can do it whichever direction that we want, to where they have an anterior airway or, and bougies really helped us be successful. That being said, again, going back to the, not the bougie, I'm sorry, the stylet. When the bougie came into our ambulances, it was mainly for difficult airways where all we could see was a grade 3 view. And instead of just, sticking the tube blindly and not knowing if we were in the esophagus or the trachea until we started bagging and either got vomit up in the airway or no CO2, because we haven't always had CO2 either. It was just a way of being able to feel those tracheal rings, or you get in the esophagus and there's no resistance, there's no nothing, or when you get what's called hang up and you hit the carina and it decides to go one way or the other. So in the traditional bougie actually is a 2-person procedure. So, and you need to leave that laryngoscope in, because if you, as the paramedic puts the bougie in and then pulls the laryngoscope out, the epiglottis just falls over on top of that bougie, and now your epiglottis kind of forms an obstruction while you're trying. You can cause injury to the epiglottis. So again, going back to the Kiwi method, if you have a grade 1 or 2, I don't think it matters if you do it or not. I mean, I think it's user preference. But if you truly have a grade 3, the bougie will not help you out with knowing that you're in the trachea versus the esophagus, just because you won't be able to feel that tracheal clicking through the ET tube that you're holding. If that makes sense.
Yeah.
But they're both great tools.
Yeah. Let's move over to pediatrics for a minute. There's a huge debate right now about cuffed and uncuffed, and for pediatrics, and I know it's always been like, uncuffed. Is there a switch? Is there a change?
Yeah, I think again the education. So we taught in PALS since PALS has been PALS, that we use uncuffed tubes in pediatrics because the tracheal ring was a functional seal.
Yeah.
And that the trachea on pediatric patients is so vascular, if we don't have a way to control our cuff pressure, we can actually cause necrosis and therefore other bad things that can happen with that pediatric or infant airway. So over the years, they've developed devices to test your pressure, your cuff pressure. Respiratory therapy does it in the hospital all the time. And then they actually did more studies and usually it was from the ages of 1 year and below that you definitely had to use an uncuffed tube. Now we know that basically it is okay because of the studies that they've done to use a cuffed tube if you can feel your pilot cuff, make sure it's not too tight.
Yeah.
And then they also found that through the years it was too difficult to give enough ventilatory pressure to these kids who have increased intrathoracic pressure because their airways are much smaller and that Bernelli stuff we talk about. But so just what kind of topped it off for us, especially with Dr. Lewis, we recently had a case, and I believe the child was 2 years old, where we intubated it with a uncuffed ET tube. We couldn't ventilate the kid. We couldn't get the pulse oxes up. And the kid was hypoxic for a large majority of our transport time. And then as soon as we got to the ER, they actually switched out and put a cuffed ET tube. And they were able to get intrathoracic pressure back up higher. The kid's pulse ox immediately jumped to the high 90s. Yeah. And so that's when we kind of started. And actually PALS, if you guys have taken PALS in the last 10 years, they have switched their stance from uncuffed to cuffed ET tubes. And it's mainly because of ventilatory pressure and hypoxia and things like that. So we should, in all of our trucks now, we should have cuffed ET tubes from sizes 5 and below. So awesome. We already had 5.5 and above cuffed, so.
Yeah. All right, so we've given our meds. We've done our preparation. We have our pulse ox coach. We have our failed airway devices out. What are those failed airway devices? I know we have the iGel and the Crike, but kind of go into those for me. Why? Talk to me about which one is better, which one. Why would I ever go to Crike?
Right. So we've always said Crike is a can intubate, can't ventilate scenario, right? And that's why we go to the cadaver lab and practice on those. It's why we hit Crike in the academy, doing it on the little dummy head kind of thing, just getting motor muscle memory and our technique down. But go back to the 3 strikes and you're out. We allow our paramedics and EMTs hold them to that. Our paramedics should only ever have 3 attempts at intubation. The studies are pretty clear, and I showed that study during the academy that every attempt after your first attempt, your complication rates, which are quite a few, skyrocket. They double, triple, quadruple for every attempt after your first attempt. The study also shows, and this is an anesthesia study, so it's probably even worse for us, that after your first attempt, every subsequent attempt drops by 40%. Wow. So on your third attempt, you have like a 20% chance of getting them intubated anyway. So our number one go-to would be our supraglottics, which for us is the iGel. The thing about the iGel is anatomy is anatomy. It doesn't work for everybody. But It works for the vast majority of our people if we pick the right size. So I think that's one thing. Whether maybe an IGL has been put in before we get there. I think our EMTs and medics need to determine, is that the correct size for that patient? And the size, we use the height.
I was gonna say, so height versus weight. I know that on the package it says weight,
Right.
but we do.
Yeah, and
height.
we learned a long time ago, after when we used to carry the King.
Yeah.
We carried the King and the LMA Supreme, and then we got the iGel. We found that when we were using the European packaging, where it was weight, we know that, for instance, I'll just make fun of myself. When I first started here in EMS, I was 160 pounds and could see my feet without bending over, all that good stuff, But I was a very thin guy. And now I've gained, 2 or 3 pounds in the years that I've been here.
Yeah.
So, but of those maybe 30, 40 pounds that I've gained in my 40 years of EMS, my airway hasn't changed. My body weight, fat has changed, but my airway dimensions haven't changed, and neither has my tidal volume. So it should be, what does change the size of an LMA, iGel, or an LMA, or any of the superlotics, is actually your height. So a short person's going to need a smaller iGel than a taller person. So what we do is anybody under 4 feet tall should get the yellow or the 3. 5 to 6 feet tall, which is 95% of who we transport, is going to get the 4.
Yeah.
So it doesn't matter if they're 400 pounds. Their airway length hasn't changed. Anybody over 6 feet needs the 5, or the orange. And then always, if it's not ventilating correctly, then I think our best next choice would be try our hand at OP, MPA, bag valve mask, see if we can just ventilate them. We know we don't have to intubate, and we don't have to have a secured airway, but we have to ventilate and we have to oxygenate.
So speaking of that, BVM is an acceptable airway, right?
Oh yeah.
Yeah. I mean, if all else fails, I'm going to bag my patient, right?
Yeah.
It's not that it's a bad thing, or that it's it's a protection, right?
Right.
Because if I can't get an iGel in, I can't intubate my patient, and for whatever reason they've got maybe a shorter neck, and they've got lots of body tissue up here, and I can't correct them, I can bag them, right?
Hopefully.
Yeah, hopefully. I mean,
I know there's always those patients that we're not going to be able to bag either for a variety of different reasons. But I think a caveat to lengthy bagging is you got to drop an NG or an OG. I mean, you can form a functional seal with a mask, especially with our new ambu bags around an NG tube, because we all know no matter how well we bag or how well we think we bag, that air, a lot of that air is going to always go into the stomach. Increases our chances of vomiting, increases our or decreases our ROSC rate. If it's a cardiac arrest, it can make us hypotensive because of increased intergastric pressure, moving the diaphragm up, and pressure on the phrenic nerve and bradycardia and all that stuff that goes along with it. So an NG tube or an OG tube is imperative. And
so we should probably be getting that out when we do all of our preparation, right?
Yeah.
Just getting that NG tube out. I mean, it should be an automatic thing. Even if we know we're going to put a tube in, it should be an automatic thing. I'm already in there, so go ahead and just thread that tube right on in.
Yeah.
And I mean, it makes it super easy, right?
Yeah. I mean, while you're there, throw it down. There was another point I was going to make about the. There's some you're going to have to edit. Let's see. Let me regain my thought real quick about that. So another caveat about bag valve mask is you have to bag correctly. So the days of hyperventilation are gone. The days of squeezing a bag with 2 hands are gone. We physically have to instruct and teach our first responders and firefighters that they can't squeeze these bags with 2 hands anymore. They have to follow the safety features of our ambu bags. They got to keep the manometer in the green. They got to keep the rate down. We know that rapid bagging, excessive bagging is really detrimental. We know that excessive pressure is very detrimental. So we have to bag correctly. And even bagging correctly, though, you're still going to get some air in the stomach.
Yeah.
So that's why no matter how well we think we do it, that NG or OG tube really needs to be in place.
Yeah. So we've talked about the eye gel. Let's move on to the cric. When would I cric a patient? I mean, I know it's that can't intubate, can't ventilate type of patient, but
Right.
I get into my second attempt or even my first attempt of, laryngoscopy, and I'm in there and I look and I'm like, man, this sucks. I don't have a good view. I can't see anything. Is that the time to maybe think more along those lines, or should I go back to trying an eye gel first? Should that I guess the question I should ask is, should that cric be my absolute last resort and only thought of as a last resort?
So my opinion, just strictly my opinion, is doing a surgical cric, because of the possible complications you can get from those as well, should still always be our last resort.
Okay.
So I think we should always go from once we've determined that I can't get them orally intubated. We haven't even talked about nasal intubation yet, but nasal intubation still really has its place in EMS. And the two people I think of specifically are ACE inhibitor-induced angioedema, which is a high risk for surgical cric, and then morbid obesity. Yeah. Those people are very difficult to intubate. You may have to do a nasal intubation on them. They're also going to be very hard to cric. Eye gels probably won't work. Bag valve mask probably won't work. So I once we get to the I can't intubate, can't ventilate, I think if you always start at the most basic and move to the most advanced, worst outcome possibility thing, then we're not going right to that choice of, now I've put a hole in the neck, I can't do anything else, and now maybe I can't get that tube to pass.
Yeah.
I can't bag valve mask them if I needed to because I've got a hole in their neck. So I think, and luckily for us, our medics are pretty outstanding at gaining airway. So as long as they're in, we do very little crics in our system, sometimes not even one a year.
Yeah.
But I know there's been some cases here recently, were just nightmare cases where who knows? I mean, who knows if that would have worked or not. But again, that's why I urge all of our paramedics, whether you're a brand new paramedic here, a paramedic student, I don't care if you've been a paramedic here for 30 years, if you haven't done a cric in 30 years, man, get to the cadaver lab, because I want your confidence level high to when you have to cut into a neck, you've done it. You've done it on a dead person. You've done it on a cadaver. And you've probably done it 10 times on a cadaver. And so if you have to do it on a real person, you have a lot of confidence, because that's one thing that will shake a medic to the core when they have to do a surgical cric. Before we utilized rapid sequence intubation, especially on a helicopter, we did, I wouldn't say we did 100 crics a year, but we had difficult airways because of trismus and masseter muscle spasm, and we had no way to ventilate and we had no way to intubate them because we didn't have paralytics to, relax them. And our cric rate was, I don't know, probably maybe 5-10 a year, maybe even more. But now we don't really have to cric hardly ever because of rapid sequence intubation. That's one of the benefits of it. It allows us to intubate people we normally couldn't.
Yeah. Let's switch gears and talk about what meds should we be pre-medicating with, and what meds should we after we've already intubated. So let's start with those pre-medications. So should we be looking for those push dose pressors for hypotension? Right. Is that something that we should be concerned about before we intubate or after we intubate?
It's not the direct pharmacology of the medications that we use that tend to cause some issues for our patients. I mean, we intubate really healthy people that are trauma. We intubate a lot of unhealthy people who have 5 comorbidities that are really and generally sick. So what we've usually said, even in the case of people who maybe have CHF or pulmonary edema, most people need a little bit of volume before they get intubated. So it's the physiology of the drugs that we push, not the pharmacology, if that makes sense, of what they do. So we take somebody who's got a catecholamine surge, they're ramped up, take the COPD exacerbation patient, they're using all of their FRC and they're basically fight or flight to live. And then we come in there and we give a paralytic and a sedative and we make everything nice and calm. And the body just kind of wants to go, oh, this is not bad. We'll just keep going down.
Right.
And then they get bradycardic, asystole, severely hypotensive. So normally, even in like normal healthy patients, a little bit of volume is good. But that takes time, right? So that prevents that post-hemodynamic collapse in the critically ill patient, post-intubation. And that's a real thing. And I bet many of our medics, and I know all ER docs have experienced somebody who you've RSI'd or intubated and everything was fine before, and now afterwards they just crash and burn. That's a really well-known phenomena. So where I know that giving somebody fluids is going to take time. We're talking 5-10 minutes to get 300 or 400 cc's in them. Push dose pressors, man, it's instant. I mean, you throw 10 mics, and it can be, you look at somebody and you just have a hint that they're going to crash and burn after intubation. Their pressures are soft before you intubate them. Their pulse oxes are borderline. Their heart rate's borderline. I mean, those are the good patients that you're like, you know what? I'm going to take 30 seconds. I'm going to mix some push dose pressor, and I'm going to be ready to go. So either I'll bump them prior to intubation, or I'll be ready to go. So as soon as that tube's in, I'm going to grab a pressure. I'm going to look at my heart rate, and then I'll be ready to go with 10 mics, 20 mics of epi of push dose. And so I think some patients are more appropriate for fluids, but your sick patients, I would forego the fluids and just go to push dose, just because it's instant.
Right. So on the flip side, what about post-intubation? What meds, what are we doing after we've intubated the patient?
Yeah.
We've got the tube, we're bagging, what are we doing after that?
So when I would say classic rapid sequence intubation, is Etomidate, Rocuronium, intubation followed by Versed fentanyl. That's always the classic, easy, straightforward rapid sequence intubation. So I think it's clinician's choice, and I think it is hemodynamic driven choice after they're intubated. So I think the typical patient is great for Versed fentanyl, and I think it should be aggressive Versed fentanyl, not every 20 minutes. But if you're using Etomidate, remember that Etomidate's really short acting. So whatever their level of consciousness was before you intubated them, within 7 to 8 minutes, that's what's going to be their LOC, but they're now paralyzed and you don't know what it is. So I think ketamine, if their pressures are soft, I think if you use ketamine to induce them, I think that you should probably stick with ketamine. There's a new trend, and this is not only in EMS but also in emergency medicine and ICU medicine, and it's backed by research that probably sedation post-intubation we should avoid as much as possible. And I know Dr. Lewis has said in our clinical ops meetings that he would rather our medics just give a ton of fentanyl. And I'm not talking 25, 50 mics of fentanyl. I'm talking about, give 100. Don't be soft on it, but give 100 mics of fentanyl. 5 minutes later, give another 100 of fentanyl. 5, 10 minutes later, give another 100. But I think initially, a little bit of benzos isn't going to hurt anybody. And in the short amount of time that most of us have our patients, and I would say Greene County and a couple surrounding counties around Greene County, given 5, 10, 15 milligrams of Versed will have no detriment outcome at all to that patient, and they're staying sedated. Other than that, maybe people coming from Mountain View, Summersville, I think maybe they could be better off given 1 or 2 doses of Versed and then just sticking with the fentanyl. I know they try at all costs not to sedate people in the emergency room and in the ICU, but they have a different reason for not doing that or withholding that. But as for right now, we have not changed our protocol. Our protocol is either Versed and fentanyl, it should be both, or ketamine. If you give ketamine, there's no need to give fentanyl or Versed. It's a stronger drug than both of those combined. And it's prolonged. You don't have to give it as often.
When do I need to reparalyze? Because we talk about that too.
Right. So technically, we don't ever want you to reparalyze after the tube is in. Because it's unnecessary, and there's studies that show the longer somebody's paralyzed, the worse their outcome.
Right.
Those aren't necessarily pre-hospital studies, but they're emergency medicine and specifically ICU medicine studies. So I always teach that there's two reasons you should paralyze in the field after intubation. The first one is if you've done your due diligence with sedation, whether it be ketamine, fentanyl, or Versed, and they are coughing, gagging, you're going to lose your tube, they're wiggling around, then for patient safety, they need to be paralyzed. The bigger issue, and the issue that is probably the biggest issue, is on head injuries, where again, you've done your due diligence with sedation and pain management, and they are ventilating on their own enough that they're driving their CO2 down to unacceptable levels. And so if you remember the H-bomb study, if you remember that study and listen to that H-bombs lecture that's been in competencies a few times, we show it in the academy now. There are, and it's not just one or two studies, it's dozens and dozens of studies that show if your CO2 on a head injury drops below 35 even once, or it goes above 45 even once, it is a 10 to 20-fold increase in their mortality and morbidity. So they don't know it. They're killing their head. So people who are hyperventilating, their CO2s are in the high 20s.
Yeah.
They're killing their head. We've got to paralyze them and take control of their ventilation and get their CO2 normal between 35 and 45. And those are the only two reasons that I can think of why somebody needs to be paralyzed after intubation. But obviously, in our environment, sedation and pain management is not an option.
Okay.
It has to be given.
Yeah. Makes sense. All right. So I think we've covered a lot. I think we went from basically preparation to post intubation, right? Is there anything else you want to throw in there that maybe we missed, or that words of wisdom from Eric Howard?
Yeah, what little wisdom I have. So just for the medics, I always want you to keep this in the back of your mind, because it is standard of care now, where we have the 5 Ps. We have our preparation, pre-oxygenation, pre-medication, pass the tube, paralyze, of course paralyze, and then pass the tube. We've added that 6th one in now, that is pass the NG or OG tube. It really is important, especially for pediatrics, and it's important for any person that we've intubated, and this is almost all of them that have been ventilated prior to our intubation, because we know what back valve mask ventilation does. It fills the stomach with air, and that can cause a lot of post-intubation problems, especially with kids, like I said. So one of the first things that ER nurses do when we get there is they throw down an NG tube or an OG tube. So if you're 5 minutes from the hospital, I think it can be withheld. I don't think it's a critical that 5 minutes isn't going to kill them. But anything other than that, I think even 10 or 15 minutes from the hospital, if the paramedic can get a free minute, and I know that's not always possible. Yeah. But if there's a firefighter riding and the firefighter can bag, or you got first responders can do this, or your EMT can do this or that, paramedics takes 1 minute to put down an NG or an OG tube, and then hook that to suction and at least evacuate their stomach.
Right.
What we've done, what we as medical providers have done unintentionally, but because of a fact of what back valve mask does, and get rid of that air. And or what they could aspirate on. So, people don't think you can aspirate with an ET tube in place, but you can, and that's how ventilator-acquired pneumonia occurs. Yeah. And that's one of the reasons we carry that taper evac tube. And most of our medics are not in the habit of hooking that to suction pre-hospital, but that's why it's there if we need it.
Yeah. All right, awesome. We've gone through our preparation. We've done a checklist. We've done all the things. So I'm going to take you through a case study here, and we'll just go through, kind of make decisions on how we're going to treat this patient, if we're going to RSI him, if we're going to crike him, or what we need to do, or what you may be looking for when that happens. So you're dispatched to a 25-year-old male involved in a high-speed MBC. He was a restrained driver, airbags deployed, with heavy front end damage. Fire on scene reports that he was initially conscious and has now become increasingly altered. This is what you find on your patient. He's found slumped over in the seat, moaning, not following commands, has gurgling respirations and blood in the airway. So, what are your first thoughts?
My first thought is, who put a simple mask on this patient instead of a non-rebreather? So other than that, so altered LOC. What did you say the vitals were?
I haven't yet.
Okay.
So we'll get those for you up there. So those are his initial vitals.
Pretty tachycardic. We're hypoxic at 84, and we're a little bit hypotensive. So I think this is a guy that we got to do everything we can with nitrogen washout to get his sats up. We would not want to RSI somebody who's hypoxic.
Okay.
That sounds crazy, right?
Yeah.
Because
that's like the indication that the patient needs to
the guy's hypoxic, we got to intubate him.
Yeah.
The problem is when you intubate somebody who's hypoxic, or we RSI somebody who's hypoxic, it sets up a pretty bad triad of that patient spiraling down and not recovering very well. Maybe not a 15-year-old head injury patient, but an elderly patient with multiple cofactors, codependencies. And so we got to do everything we can to get that SAT up above 90, because when we say, we can't let our saturations drop below 90 during our intubation attempts, now we're starting below 90 on our first attempt. And so we're like, okay, how low do we let that go?
Yeah.
If we have to do 2 or 3 attempts, how low do we let that go? And so we got to do everything we can to get that SAT up. So we need to make every effort to get them to that safe apnea. So what I would do on this guy is I would immediately put him on high flow nasal cannula, 15 liters by nasal cannula. And just as a reminder also to all of our coworkers, I think on somebody like this, I think it's really important that we get a baseline CO2.
Yeah.
So throw a nasal cannula.
So this guy was a little he was all over the place with his end tidal.
Yeah, there's his end tidal, 21. Yeah. So 21's way too low, right? So a CO2 and a head injury at 21, that's a perfect indicator that they've got to be intubated. And the best, safest way to do that's rapid sequence intubation. But we got to get them non-hypoxic before we do that.
Right.
So you can always bag CO2 down. You can't bag CO2 up.
Right.
They're breathing what they're breathing. Yeah. So what I would do is non-rebreather, trial a nasal cannula, crank it up to 15, a non-rebreather. Give that a minute or two. If that SAT's not starting to come up, I'd go right to bag valve mask. Bag valve mask is 100% oxygen. Non-rebreather is 70% at best.
Okay.
Regardless of what we're reading in all of our textbooks. Too many studies to count have shown that non-rebreather, especially in a pre-hospital environment, is nowhere near what our textbooks say they are. It's 70% at best, and that's in a laboratory studied patients. And that's not with facial hair and a mask hanging half off their face and all that. So, and then I would do every effort to bag them up. And since that's a relatively young person, I see no reason why we couldn't bag that patient up to 94 or 95. And then the safest way to intubate a patient like that would be definitely a rapid sequence intubation. You mentioned blood in the airway. Yeah. That is an issue. So that may be one of those patients that, you try once or twice and you can't get around that blood. And I know probably many medics in this service have had patients where regardless of how fast you're suctioning, that airway just keeps filling up with blood, these big basilar skull fractures. And if that's the case, I think the next safest thing, because what you're doing, if I try to bag valve mask that person, where's all that blood going? It's got to go into their airway or into their stomach. So I think the next safest thing there, if you can't get direct laryngoscopy and suction isn't working, I would actually try an eye gel, because what an eye gel will do is it'll bypass all that bleeding, put that functional seal from here to right there, and maybe you can ventilate them without blowing that blood all over everywhere. And then if that doesn't work, I think this is a good patient, because of the blood in the airway, to go right to a surgical crate.
Okay.
Just my opinion. And I would use Etomidate on this person and Rocuronium.
So you got a little ahead of it, but so let's say that you did your BVM, you did your suction, okay? These are your vitals now. You got a good end title, a little bit better than what was before. 'Cause it was all
26.
over the place.
Better than 21, but still not good.
So on this one, like, are we at that RSI stage yet?
I think definitely.
Yeah.
And also, two key indicators of I got to intubate a head injury is CO2 and what are my pupils.
Okay.
So if you got unequal pupils, you're starting the herniation process, and then that CO2, we gotta control that CO2, and the only way we can do that is to paralyze them and ventilate them on our own.
So on this guy, we talked about Etomidate and Ketamine. He's probably got a hidden injury, right? So Etomidate's going to be our better choice for this than Ketamine is, just because of that cerebral protective.
Right. That being said, if a medic decides to use ketamine on this patient, it's not like they're doing them any harm.
Yeah.
It's not like the wrong choice.
Right.
It's just Etomidate is
Probably
chemically
the better option.
Yeah.
On this patient.
Pharmacokinetics of Etomidate are better for heads than ketamine. Ketamine isn't harmful, so.
All right, so we opted to RSI. We didn't ever get his SpO2 up real high, but just because he had a lot of blood and various things in his airway.
All right.
So this is when you gave your meds. These are your vitals. Am I worried about like blood pressure here? Should I have maybe given some push dose before I did
We're
this?
not intubated yet, right?
So we've pushed our meds though.
Okay.
We're right there at that tipping point.
So on this, since this is trauma, we try to withhold push dose pressors with trauma.
Okay.
And that's been kind of a mantra for all of emergency medicine. This is the guy that, he's below that 100. So now we've got that hypotension, hypoxia, hypocarbia.
Right.
So we got 3 of the 4 H bombs.
Right.
And so we got to correct everything as quickly as we can. And this is the guy that I have the fire department squeezing the hell out of that bag, trying to get as much volume in as we can.
Okay.
So if he does have internal bleeding and we do push dose epi, it's actually going to make it worse. So that's one of the contraindications of push dose epi is, trauma.
Trauma.
Yeah, so we try fluids first.
Yeah, definitely. Okay.
Yeah, but everything up there is the issue.
Yeah, right.
And the thing that makes me think that he really needs fluids way more than push dose epi is that heart rate.
The heart rate.
Yeah, and so push dose epi is going to probably jack that heart rate up to 160, which will probably make the pressure even worse. And so, yeah, fluids.
All right, so we have intubated our patient.
It's about time,
right? so again, it's not a rush thing,
Yep.
So we've intubated our patient. So these are our vitals afterwards. Am I concerned with anything at the current moment?
It's more gooder. I would expect tachycardia just because he's trauma. The blood pressure is fine for me for trauma because permissive hypotension is not a thing in head trauma.
Okay.
So we can't go, the pressure's 90. That's okay because he's trauma. We got to get our MAP, 70 or above. So that one is 76 is our MAP on that. CO2 is great. We're between 35 and 45. Pulse oximetry, I would be doing maybe more to increase my O2 sat if we had a ventilator. There's a lot of ventilator tricks you can do.
Yeah.
But I would do a little bit, to maybe try to get that pressure a little bit higher.
Okay.
Maybe 110, my own opinion. I like where that CO2 is.
So am I still good with like fentanyl and Versed for post-intubation? Or should I go with maybe ketamine?
Yeah, I'd be careful with Versed, because what if I give 5 milligrams of Versed or even 2.5 and now I drop that pressure back to 90?
Yeah.
Then that's not good either. So in a hemodynamically unstable post-intubation patient, ketamine would be my choice.
Okay. All right.
And then no rock unless you really need it.
Yeah. All right. So talking about vents, we did a vent tweak, and we did suction again. And so now we've got a little bit better vitals, right?
Yeah, I like it.
Yeah. So we did all of those things to try and make sure that our vitals got better.
Yeah.
And made a hemodynamically stable patient, right? From that very beginning where he was not hemodynamically stable.
Right.
So, I think RSI in this case would have been great. What about DSI? We didn't talk about DSI.
No.
So what about DSI? Like, could I have DSI'd this patient since his SpO2 was a little bit worse?
Yeah. DSI is great for anybody who's hypoxic. So the whole reason why we would do a delayed sequence intubation is to dissociate that patient. And the only way you can do a DSI is ketamine. So again, Etomidate's going to be out if we decide to do a DSI. So DSI is good. You dissociate them. They allow you to get their saturations up a little bit more with several different ways. You can do it with, you can do it with nasal cannula, non-rebreather nasal cannula, BVM. You can do it in nasal cannula, maybe throw CPAP on there. CPAP isn't really contraindicated on trauma or head injuries. And once their SAT gets above that 90% threshold, we prefer 90 to 95% threshold, then we can push our rock.
So let me ask you this then. We talked about it at the very beginning when we were going to RSI. We wanted to use Etomidate, okay, because of that neuroprotective feature. But with his SpO2 at like 86, even with bagging and the apneic oxygenation and the non-breathers and all that stuff, we couldn't get it up above 86, 87. So what am I more concerned with? The hypoxia? I mean, I know I'm all concerned about all of it because we had 3 of those H-bombs, but what am I more concerned with in this instance? Do I want to do a DSI? Do I want to protect the head? Is there a clear cut answer?
So now you're really making this more difficult because you're talking about critical thinking, critical care medicine and stuff. So the one downfall on head injuries with bag valve mask is that we usually always drive the CO2 down when we're bagging somebody, trying to get their oxygen saturation up. We're bagging too fast, we're bagging too forceful because we think that's what the patient needs, right? So that is one downfall of bagging a non-intubated head injury, is at the expense of CO2, trying to raise the VO2. So at this point, I'm not really worried too much about the heart rate. Pressure, obviously the pressure was low, but and again, this is probably a difficult choice of what I do, because I'm going to make one better and probably make the other worse. So you're kind of damned if you do, damned if you don't, kind of a thing. So I think it'd be interesting actually to have this exact same scenario in a competency setting and ask every paramedic, how would you handle this? Get some of those critical care medics and go, what would you do with this? And see how many hundreds of answers you'll get. Ask Lewis, he may say something completely different.
Actually, we can do a poll up. That's probably what I'll do.
Yeah.
Is just do a poll up here during the video. I'll have a link for it, and then you guys can answer that question and give me your opinion on this case. Would you DSI this patient, or would you RSI him and use Etomidate or ketamine? That's what we'll do.
And to kind of reverse that too, I think DSI is a lot better for medical patients than with trauma.
Right.
So seeing that this is a trauma is kind of a train wreck, I would always choose the direct ventilation, typical RSI, and try to do that.
Yeah, because we do think of DSI as more that patient, the septic patient, or the
COPD exacerbation.
Yeah. So we think of DSI, using DSI, but in this instance, just because this was a train wreck of a patient, it could have been a viable option to use DSI.
Could be.
So
I would say it would be wrong for doing
Yeah.
it, but if you guys disagree with me, I will be tired. Anyway,
all right.
yeah.
Well, thank you for
Yeah,
coming on.
thanks.
We've exhausted our hour talking. So thank you for coming on. We'll have more of these. If there is something that you guys would like to see, shout, let me know. I think we've got some outside Mercy people lined up as well. Some EMS influencers, I guess, on social media. So I think I've got some lined up for that. But yeah, I mean, just to kind of recap for today, RSI, good thing, bad thing, great thing. Yeah.
One of the best things that's happened to emergency medicine is
7 P's, right? Gotta have those, right? Prepare, make sure that you've got everything done before you actually get
use your checklist so you don't forget something.
There's plenty of options. That particular checklist that I got to show you guys was actually from Debbie, the PDF on it. But yeah, just use your checklist. I mean, there's really no point in not using that checklist.
This one I have that's been distributed.